right, gang, we're back, and let's talk about zapping people. I like zapping people, right? No, actually, I don't, because that means it's usually got a lot of work to do. But we're going to talk about the electrical therapies now, and really remember some things that I need to kind of point out to you about electrical therapies that you need to know. I wish it was just as simple as let's zap them. All right, so understanding defibrillation. My simple way of describing this is, think of this as you're blasting the chest with energy, and because you blast them with energy, it actually does a reset to the heart, okay? So remember that when you want to reduce, there's a couple things that can influence the defibrillation, or cardioversion for that matter. So chest wall resistance is one of the bigger ones, where you got to have paddle pressure, paddle skin, or patches, again, paddle surface area, the number of previous counter shocks, and inspiratory versus expiratory phase at the time of the shock. So again, let's stop and think about it. If there's more tissue or it's expanded tissue, there's more area in order to go through in order for it to work. You've got to have good adherence to your pads. If you're using paddles, you've got to have good firm pressure down on the paddles, about 25 to 30 pounds. Most people, use the quick pads. They want to use them now because you can do a faster cardioversion or defibrillation with it. That's why the paddles have really gone out of favor. You can truly do it without actually being close enough to the patient. So again, your generation has probably never seen somebody actually defibrillated with paddles before, okay? Paddles, I think, actually do a better job of defibrillation. However, it has to be done correctly, all right? But the biggest thing is you got to have good adhesion with that. And again, the paddle area is so big nowadays. Again, the patches are probably around 1.5 to 2 sizes they would have been with the paddle use. So what makes a successful defibrillation? If they go into VFib, the sooner that you can defibrillate them, the better chance you have of it working. For every minute in which you do not provide a counter shock, their chances of them surviving is 10% less. So let's do the math there. If you go 10 minutes being in VFib without being defibrillated, your chances of returning are very, 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 they go into the very slim, less than 1% chance category, okay? Condition of the myocardium, if they've had such extensive damage to their heart, there's nothing there essentially to counter shock, okay? Heart size and body weight, again, bigger the tissue, the probably the less chance that you have, because or body weight that has to go through additional tissue. Now the good news is that most modern defibrillators actually measure the resistance and adjust appropriately. And it's called impedance. We usually don't actually get to see what that number is, except if you look on it. And on your biphasic monitors, one of the cool things about a biphasic monitor is that it actually measures the impedance between the paddles and appropriately adjusts. The good news is you don't ever get to see it. On the back end, I can pull it up on the monitor so I can see how many joules of impedance there were. So, and again, the machine adjusts appropriately. All right, if they've been shocked before, the chances of a shock being effective is actually less. Now, major controversy on that one. But that's why most machines escalate electrical energy when doing a defibrillation. So again, it's here at CF we do 200, 300, 360. It's primarily because we have all life packs, but we're supposed to follow the manufacturer's recommendation. Now the funny part to that is that most manufacturers put in to follow current ACLS guidelines. So it's really kind of funny when you start reading that, and they both look at each other and go, "You decide how much energy." Make sure that you got the pads in the proper place. Again, sternum apex is the standard placement. I actually think the anterior posterior position does a better defibrillation, okay? But again, an anterior, posterior, I think, again, there's less area for it to travel through. It's directly over the heart. I think that it works really good, okay? Make sure that you got the placement there. Make sure that you got good, proper size pads. Make sure you've got them stuck on very well. And a properly functioning defibrillator. If you don't have a properly functioning defibrillator that gets tested on a regular basis per the manufacturer's instructions, and again, that's every 6 months, by the way. They should be tested. So when you're going in to have your monitor serviced, everybody's griping and complaining, oh, I don't have to do that. But guys, seriously, the testing function takes about all of 15 minutes, okay? It does not that hard to do, all right? But it makes sure that your equipment is working the way that it's supposed to do. Now, this is an older Philips model. Again, the Defib, we all agree that that's bad, okay? So again, but notice how we've got the energy selection over here. So we can, now I will tell you this, guys, the Philips, they start out at 120 and then they go up to 200, okay? I'm sorry, they usually start out at 150, I'm sorry. So their manufacturer, well, it kind of depends on the model. Some of them say 120, some say 150. But they say that the highest energy level that you should go up to is 200, okay? Now again, for a LifePak 15, it'll actually have defibrillation at 200, 300, 360, okay? Got to know what piece of equipment you got. All right, so again, you're going to apply the paddles, or in this case, the pads, the quick look pads. Now again, you're using sternum and apex. Remember, negative pole, positive pole, and as we all remember from lead placement, that's lead 2, right? So again, you're going to charge the paddles. Notice how he's holding C-spine. He probably is not going to hold C-spine when they are, again, right before you shock. You should reconfirm that patient is actually in a shockable rhythm. So if you look down and for some reason they're no longer in a shockable rhythm, it's weird, but it does happen. Don't shock them, okay? And by the way, if you've got an organized complex that's not wide and fast and regular, you probably shouldn't be defibrillating them, okay? Really should not be, all right? So again, we're going to make sure we're clear, we're all clear, I'm clear, you're clear, we're all clear. And then you're going to take and make sure that you say that. Verbally and visually check for that, all right? I can't stress that enough. Look up and down your patient. I'm clear, you're clear, we're all clear, okay? Because the last thing that you want to do is have somebody touching. Now, I have to premise this next statement. Dr. Frank regularly will have somebody defibrillated where he's still doing compressions. He says that he feels a little tingle. Again, I'm going to tell you until they change the science, and by the way, I've also watched the Mythbusters where they did it. Guys, again, clear the patient and then shock them, all right? It's just a safety thing. I have been shocked by one. It was a little bit more than a tingle, okay? So, but again, I didn't have any lasting effects from it. But again, the point is that if you get a little electrical zap when you shouldn't, could it cause a problem? That answer is yes. So again, deliver the shock. Once you deliver the shock, now she's reconfirming the monitor. We're not going to reconfirm the monitor. We're going to go straight back into compressions, okay? Don't check for a pulse. I'm going to repeat this. Don't check for a pulse. Because if you're doing a defibrillation, go start doing compressions, all right? Now, if you're doing a cardioversion, then this is actually 100% in play, okay? So let's talk about cardioversion, a good way to step into it. Excuse me, guys. Unstable tachycardic patients. So if they got a perfusing VTAC, but they're unstable, if they're in supraventricular tachycardia, the P stands for paroxysmal. It means it's going in and out of it. SVT is fine, guys. If they're in a rapid atrial fibrillation or they have a 2-to-1 atrial flutter or faster, long and the short, those are the guys that we are indicating a cardioversion for, and we need to let them have it. It's similar, except the only thing that we're going to do is turn on the synchronizer, okay? The sync button. Now, most modern defibrillators, the sync button's only good for one time. Once you hit the energy button, it turns the sync off. But you're always going to check that before you try to shock with a cardioversion. Always make sure that the sync button's on. With a defibrillation, always make sure the sync button's off, okay? So the other thing that you have to do with a synchronized cardioversion is hold the power button. You're going to need to hold the shock button, okay? Because again, it takes 2 or 3 beats for the synchronizer to actually link up with where the R wave is, all right? So you're going to press and hold. It might take 1 to 2 seconds for it to actually work. So again, when are we going to do these things? Again, we're going to make sure that the procedure for those, we're going to make sure that we got to make sure that we're going to defibrillate or cardiovert somebody correctly. We got to make sure that the indications are there. We're going to double check that right before we administer the shock. Make sure that the pads are on. We make sure that they're good. We're going to make sure that, again, if they are pulseless, good CPR. But if we're having to analyze, again, we don't do CPR during any type of analysis. Again, double check. If you're going to cardiovert somebody, by the way, they're unstable. Now, if you've got enough time to give them a medication, maybe 100 mics of fentanyl, maybe 2 milligrams of Versed. I'll give you a little hint, though. If they're unstable, they probably have the cache. And one of those caches is probably the hypotension part, okay? So if they've got hypotension, we probably shouldn't be giving them pre-medication because the pre-medications that we're going to give them, it's going to drop their blood pressure even more. Again, if I'm cardioverting somebody in a controlled setting, we obviously want to make sure that we have sedated them. But if they've got already altered mental status, if they've got hypotension, we're not going to give a pre-medication. We're going to look at them and go, I'm very sorry, this is really going to hurt. And again, it is going to hurt. It's going to be like a mule kick, okay? And they're probably going to let you know it, but they'll be complaining because they're alive and they're talking to you, okay? So in a way, that's kind of a good thing. All right, for our energy for synchronized cardioversion, here in school, 100, 200, 300, 360. But Scott, I read that if the patient's in atrial tach, we can start at 50. You're absolutely correct. Do I want you to remember that? If you can, be ready to justify it. 100, 200, 300, 360. Okay? Matter of fact, if you have an A-flutter or A-fib, you're probably going to have to start at a higher energy range. Probably around the 200 before you get a true capture. But while we're in school, 100, 200, 300, 360 for your cardioversions. All right? The other way I remember this, excuse me, guys. The other way I remember this, cardioversions is it starts with the letter C. Okay? The letter C in the Roman numerals is 100. Okay? So if you cardioversion start at 100. Cardioversion, it starts with a C, and C means 100 with Roman numerals. So that's how I remember how to remember those. Transcutaneous pacing. So where your defibrillation is a shotgun blast of energy all through the myocardium. Your cardioversion is a sniper rifle shot directly onto the R wave to perform an electrical reset of the heart. This actually provides electrical stimulus to the heart. All right? Really good for bradycardias, really especially good for high degree atrioventricular blocks or AFibs with a slow ventricular response. It's very rare that happens, but it does. Other significant bradycardias, we do not, let me cross this out right here right now. This is kind of an older slide. So let me cross this one out right here. We do not use pacing for asystole. Say that again for me. We do not use pacing for asystole. Now, I will tell you there are a dumb exception to that. That would be an organophosphate poisoning. But guys, most of the time, we do not use any type of pacing for asystole. Get that out of your skull. We don't do it. All right? Now, how do we do it? We apply the pads, make sure everything's good, make sure it's dry, and then we're gonna start the beats. We usually start those at 80 beats per minute. Most of your machines either default to 70 or 80. We can preset those, but most of them start at 80. And then the current output starts at 0. I'm perfectly okay with you guys starting at 0, but the key thing is to turn it up until you get a capture. Okay? What do I mean by the capture? That you see a wide complex behind the pacer spike. That is known as electrical capture. Okay? Once I get electrical capture, I want to increase it 10 more milliamps, and then I'm going to reach down and see that if I've got an actual pulse. Okay? So whenever you feel for that pulse, it should be coming right after your pacer spike. So, or probably the cheater way to do it is to once you see the muscles contracting. Because remember, not only is it going to contract the myocardium, but it's going to contract all the muscles that it goes through. So, so by the way, the more that you turn that up, the harder those contractions are going to be. All right. And if you've ever seen somebody pace, you'll be from an external, from a transcutaneous pacer. Again, you're going to see that. So again, confirm the mechanical capture. Reach down, femoral pulse, or do their carotid. The reason I don't like to do their carotid, guys, is because it's usually twitching their neck muscles, and so you feel the neck muscle twitch, and you think that is their heartbeat. Femoral, I think, is a little bit better because it's farther away. You don't get the muscle contractions like to do up in the neck. Either one, by the way, does work, guys. But the key thing is make sure they got a pulse. Okay? And once they got pulse, hey, we're great. Now, if they don't have a pulse, this is where the art of pacing comes in. We usually turn up the milliamps until we get the pulse. I usually go 10 to 20 higher, and then see if I've got the mechanical capture. The other thing I might do is turn up my rate another 10, especially if I'm down in 60 or 70 land. 80, I might go up to 90, maybe. But I do 10 to 20 milliamps, and then I go back and raise the rate a little bit, and then I go up 10 to 20 more, keep going up on the milliamps, okay? Never go above 100 on your speed. Never, ever. There's no reason for it. 80, truth be known, 90 is really pushing it, okay? 80 is just fine, all right? But turn up the rate just a little bit to make sure that maybe it might be where it's just not catching the rate for some reason, okay? So remember that most of your pacemakers, your transcutaneous pacemakers, are demand pacemakers. So if you've got an underlying rhythm that is faster than what you've got the heart rate set at, it's going to go for that underlying rhythm first. It'll say, hey, you know what? We got an electrical, the heart's doing what it's supposed to do. We're going to shut down for a little bit. We're going to still monitor, but we're going to shut down. And that, again, that's actually a good thing, because let the heart do it itself if they can. If you're going to do cardiac pacing, again, obviously we got to have our lines. Guys, you got to put your electrodes on for pacing, period. 4 leads got to be on, okay? Again, try to keep it away from the sternum apex, because that's where your pads are going to go. Get your vital signs, contact your medical direction. If you need to pace, let them have it. Put the cardiac pads on, apply your electrodes. Now, there are some older machines, guys, that have their own pacemaker pads, okay? Most modern machines today, they have this guy right here. This is they do the same thing as far as defibrillation, cardioversion, and they also do the pacing. So we don't have to mix and match there, okay? Again, you connect your electrodes and then select the pacing rate and then turn up your milliamps, okay? And then monitor for the response and the treatment, okay? So slowly go up on the milliamps, not super slow, but go where you can actually check to make sure that they've got a capture, okay? I mean, don't do it like, 10 milliamps every 5 seconds, all right? All right, the last thing we're going to do is, as far as procedures is talk about the carotid sinus massage. Again, kind of out of favor in the EMS world, but you might see it or might be asked to do it, okay? Again, we want to make sure that they don't have a history of cerebrovascular or cardiac carotid artery disease, okay? If they've got bruits, we absolutely don't use it. If they got asystole, PVCs, VTAC, or VFib, understand that if we do this procedure, that is what could happen, all right? Patients that experience any bradycardia, nausea, and vomiting, we probably need to stop, all right? Because remember, we're stimulating the vagus nerve when we do this. So again, do your full cardiac assessment. Make sure your monitor is on. I would go as far as to say you should probably put the pads on. Again, listen for bruits. Make sure that you don't have them. Again, get your IV started ahead of time before you do this procedure. Again, you should only be doing this with a stable patient anyway. And then rub either carotid, either left or right, not both, just one. And go, again, up and down, rubbing the carotid artery with their head turned to the side. And then continue to check the rhythm to see if you actually break the SVT. If unsuccessful on the one side, you can go try the other side to see if this works. Probably around 20 to 30 seconds is how long you're going to have to do that, okay? Again, constantly reevaluate your patient while doing this. But again, I can tell you right now, we usually don't do this in the field. We've got other Valsalva maneuvers. Ice pack to the face, have them blow through the syringe, have them bear down like they have to take a poop, although you're going to run the risk of messing up your stretcher. So again, there's other choices other than the carotid sinus massage. But just in case you go to a place where they actually do that, you're going to know how to do it. All right, that's enough for the therapies, and I'll see you guys on the next one.